Good morning, everyone, or good afternoon, or whatever is the time at the moment. I'm glad to see some of you. Hello, Ibrahim. And hoping to see more of you, inshallah, in person. Now, quick note before I start. We will be doing these kind of presentations every once in a while, hopefully every few weeks, unless I have a training or a traveling or whatever it is, but I'll try to keep it at least once a month. Because there's, of course, as you can imagine, there's a lot of frequent, let's say, issues or frequent points that I have seen many people basically complain about, or issues that happen to them every now and then. And I thought it will be useful, to share the information from different countries, from different cases. And I understand a lot of you work in the field and not just for Stago. So it will be useful, I think, for many of you if me sitting in the office the whole time, I would share some of the things that I learned here and some of the things that I learned from you as well. So these sessions, of course, as you have probably seen in the email, I will record them. I will upload them to YouTube. So it will be easy access for you later on. And I understand some, of course, cannot attend, so they can get back to that. I will keep it on the WhatsApp group, so it will be easily accessible. You don't need emails, you don't need anything, and it will be there as a record. Anyways, without further delay, this presentation basically covers some important points about the QC. We will not be able, of course, to go very deep into the details. That will take too much time. We will talk about calibration. We will talk a little about accreditation because it can be a complex matter to discuss. And then I will cover the analyzer validation and verification part. For a start, now, calibration is something that I think many people can be sometimes confused about. Like, why do I have to do calibration? What's the point? Why do I have to calibrate this test, but I don't have to calibrate that test? Why, for example, APTT doesn't have calibration? Why sometimes do I have to repeat my calibration multiple times? It keeps failing. My calibration is passed, but QC is failing, etc., etc. Calibration is very simply a process of me converting one unit that I have measured into a different unit. Meaning, I, for example, have measured my APTT in seconds. Okay, I need to convert these APTT readings into factor 8 concentration, for example. Factor 8 concentration is reported in percent. APTT is reported in seconds. So these are completely different units. How can I link these two units? I can simply do the following. I will bring one sample with a known concentration of factor 8. For example, I will buy a sample that is known to have 70% factor 8. Then I will run it on APTT. For example, I'm just giving you random examples here. So if my APTT gave me 50 seconds, okay, this is from this sample that I bought that has 70% factor 8. When I ran it, the APTT gave me 50 seconds. Now, if next time I run a patient sample and it gives me 50 seconds, I know, this patient has 70% factor 8. So calibration is very simply a way for me to link one unit that I'm measuring to another unit that I am reporting. That's the whole justification behind doing calibration. Converting one unit onto another. Of course, there is calibration curves, there is multiple dilutions, etc., etc., etc. But these are all technicalities that basically will do the same exact thing at the end. I just need to do calibration for my analyzer to know when you measure this quantity, when you measure, for example, clotting time, I want you to convert it to percentage, for example, or nanogram per ml, or whatever it is. The analyzer will tell you how would I do that. You will tell the analyzer, whenever you see this much seconds, based on this calibration data, convert to this much concentration and percentage and microgram per ml, whatever it is. So this is very simply what calibration is. Now, the way we do it, of course, as you are very well aware, we just have a calibrator. Now, what makes a calibrator unique? Simply, a calibrator is a plasma or material, whatever is this material, that has known concentration of the thing that I am measuring. For example, I want to calibrate, again, to keep it simple, I want to calibrate factors. I want to know how much concentration of factor 2 is in my sample. If I don't have a way to tell the analyzer, if you see this much clotting time, then you have this much factor 2. The analyzer doesn't know. It's just a computer. It just converts numbers. So you need to tell the analyzer, if you see this much clotting time, you should know you have this much factor 2. Okay? And simply this is what the calibrator does. The calibrator, again, provides you with known concentrations of the things you are trying to measure. Okay? Because if you, I assume you are well aware, our analyzers just measure optical density and clotting time. Optical density obviously cannot be reported to a clinician. What can you do with optical density as a clinician? I need to convert optical density into concentration. And this is the function of calibration. Now, beyond the technicalities of what calibration is, there is something very important and there is a lot of confusion about. Sorry. And there's a lot of confusion about. Calibration has to be traceable. What do I mean by traceable? Now, remember I told you, calibration has to have a known quantity of the thing that I'm trying to quantify. Factors, D dimer, protein C, protein S, antithrombin, whatever it is. How do I know the value of these things in my calibrator? Now, it's very simple. Yes, Muhammad, is there something? Okay, I assume it's by mistake.
I'm sorry.
Yes, Muhammad.
I'm sorry.
No worries. So for calibration, when I want to assign the values, how do I do it? How do I know for sure that this is the concentration of this factor or this protein to the calibrator? Now, there are things which are called international references or international reference preparations. These are simply plasmas. So for example, WHO prepares or sells something called an international reference preparation, IRP. Now, WHO simply has a method that science, as far as we know, okay, produced this method and is the most accurate method, for example, to determine factor 8 concentration, okay? We know it's so accurate that it only has a margin of error like 0.1%, for example. I'm just giving random numbers here. So WHO measures the concentration of factor 8 in this plasma. So I know factor 8 concentration in this plasma is 90% using this very accurate method, for example. Now, usually these methods and these things done by the WHO are very, very expensive for a regular lab to buy. They can cost thousands of dollars per sample in some cases. Then, okay, what does this have to do with my calibrators that I buy, which are just like a couple of $100s? Now what happens? If you look at the top of this scheme that I'm looking at here, and I'm displaying, it says SI unit. This is international standard, basically. Okay? So I can produce at the top a measurement that is so accurate because it's using this very, very accurate method to tell me that you have this much factor 8. But we said this sample is very expensive. So what do I do? So Stago, for example, goes to WHO. I want to buy your standard. So Stago buys the standard from WHO. Then Stago calibrates some machines that it has at its factory. So we know that these machines are calibrated with a very, very accurate material. So these machines should function very, very well. They should give me very accurate readings. But then I need to produce calibrators for the market. I cannot produce just 10, 20 calibrator vials. I need thousands and thousands of boxes. So what Stago does, for example, using these few machines, it buys plasma, for example, human plasma with unknown values. Once I run this plasma with unknown values on these machines, then I know I have this much factor 8 in these plasmas. Then, to make things simple, I don't want to complicate it too much, it's actually longer, but let's say after I took these unknown samples, I ran them on Stago machines, which are very accurate at this stage, I know that they have, for example, 100% factor 8. So then I will sell them to the customer, okay, telling the customer, we as Stago took this unknown plasma samples, and we measure them on our very accurate analyzers, and we know they have 100% factor 8. So you can use these samples as your calibrators. Now, when I calibrate my machine in my lab as a customer, okay, I can say that I calibrated my machine with something that is Stago calibrated, and Stago calibrated their machine with something that is traceable or that's connected to WHO or calibrated by WHO reference. So this means my machine calibration is traceable. There's a connection between my machine and the WHO reference, which is the most accurate one. So when I say calibration is traceable, I mean that there is a chain of calibrations that connects me to the WHO reference. Now, this is something very important in calibration, because this means that my machine is as close as possible to what's truly in my sample. We call this traceability. Now, many of you, of course, have heard from their customers, can I have the traceability certificate? I want you to give me the traceability certificate. Where is the traceability certificate? Traceability certificate must be provided by each manufacturer. Stago has it. If you need it, I will put it in the group, by the way. So a traceability certificate just tells your customer that this calibrator that I am selling you is actually connected to WHO standard. And this is mandatory for some accreditations like CAP, for example, or ISO or JCI. They tell you to give them the traceability certificate of your calibrator to prove it's actually connected to WHO standard. Now, many would say, okay, fine, your calibrator is very expensive. QC is much cheaper, and the QC has target values. Why I cannot use a QC as a calibrator? Okay, theoretically, it sounds like a valid point. However, it's very important for you to know that QC is not traceable to a WHO standard. Anything that's not traceable to a WHO standard cannot be used as a calibrator. Actually, the reason calibrators are significantly more expensive than QCs, simply to link your calibrator, make it traceable to a WHO standard, it's a very expensive procedure. It's not expensive just because Stago or Siemens or IL want to make it expensive. It's very expensive to buy these references. So to emphasize, last point to make here is only calibrations are traceable to a WHO reference. So some customers will tell you, I want the traceability for reagents. It doesn't make sense. There is no such a thing. Okay, how can a reagent be traceable to a WHO reference? Reagents don't have target values. So traceability is only applicable to calibration materials and never QCs, which is the main reason we cannot use QCs as calibrators. So now I have done my calibration for the machine. How do I verify that I have actually done the calibration properly? That my calibrator, for example, is not expired or has a problem, it was stored improperly, etc., etc., etc. Now, okay, of course, the calibrator should be as accurate as possible. But again, you cannot rule out that maybe it was transported incorrectly, it was stored incorrectly, it was having problems. You will never know until you verify the performance of your calibration using something else. This something else is the quality control. So one of the most important functions of quality control is to verify that actually the calibration that I have done is actually accurate. It's actually properly done. Okay. Again, verifying the calibration using QC is just one of the functions of a QC, but it's one of the most important functions. So quality control then, why do I really need it in the lab, apart from calibration verification? For example, APTT. I don't do calibration for APTT because the analyzer measures second, as we said. I report second. There's no conversion of units, so there's no calibration. Then why do I need a QC for APTT? QC verifies the performance of your reagents. Maybe the reagent is out of stability. Maybe it was reconstituted incorrectly. Maybe it was expired and you did not notice, etc., etc., etc. The QC verifies the performance of your analyzer because the analyzer is affected by electricity, by humidity, by temperature. It's affected by maintenance, many things. QC also verifies your performance as an operator. Maybe you're not doing pipetting properly. Maybe you're not loading the reagent properly. Maybe your samples have a problem. So QC basically verifies everything that goes into testing your sample. So QC verifies the analytical phase of me working in the lab. Okay, analytical basically is everything that involves analyzing your sample and giving a result. So QC tells me, everything that has to do with the processing the sample on the analyzer is working properly. Now, of course, as you are aware, there are many technicalities related to QC, but this is its, of course, core function, and I'm sure you're all aware of it. So now, what exactly then is a QC? Can any plasma be QC? Can I just take a patient sample and use it as a QC? Now, the answer to a patient sample being used as a QC is in most cases, no, you cannot just take a patient sample and run it as a QC. The simple answer to why I cannot is, do you know what's the concentration of the thing you are measuring in your sample? Of course, no. That's the reason we are testing a sample, because we don't know what's the concentration of a protein, what's the function of the coagulation factors, etc. So a QC is something that has a known concentration of a protein, a known activity, for example, in a clotting time. It has a known quality, okay? So when I run this sample on my analyzer, I know to say that if this sample did not measure this much, something is wrong with my system. My system is not measuring things as expected. So what is a quality control? Again, as you can see here, it's something of known performance, known quality that I use to test my analyzer, my system. When I'm testing my system, I'm talking about reagents, I'm talking about analyzer, I'm talking about electricity, I'm talking about my preparation, everything. Okay, so the QC tells me, is my system as a whole working well or no? So can I use a patient sample? No, because a patient sample does not have a known quality, does not have a known characteristic. Now, one important point, QCs are actually, for example, in a Stago case, QCs are generally human plasma. It's a plasma collected from donors. But we just said that we cannot use patient plasma. The difference between a QC that is sold to you or to the customer and the patient plasma is, when I take the patient plasma that I collected from donors, we take it to a QC department within Stago. The QC department runs this plasma on multiple analyzers, multiple compact maxes, multiple R maxes, multiple satellite maxes. Then it sees how much, what was basically the value that each of these analyzers measured. Then Stago says, within this range that I gave you in the paper that comes with the QC, within this range, okay, your satellite max should be within this range, your R max should be within this range, your compact max should be within this range. And it's one range for all of these three analyzers, if you have noticed. We don't have a range for compact alone, we don't have a range for R max alone. We have one range for all of them. But the point is, I have now a material with a known range of expectations. I know what to expect from this material, so I can use it as a QC. If I don't know how it will perform, how can I use it as a QC? Maybe it will read 50 seconds APTT, maybe it will read 30 seconds. Which one is correct? I have no idea. But if your case is out of range, of course, I cannot use the analyzer. Something is wrong. Now, again, one point that I will mention again. QCs are not traceable to an international reference as a calibrator is, which means I cannot use my QCs as a calibrator. Because for QCs, I have a wide margin of error. Okay, because usually, if you probably have heard this a lot, manufacturer ranges are wide. Okay, so maybe my QC should be measuring closer to the lower range, closer to the higher range, but this is a very wide range. If I will calibrate with the QC, my results for the patients will probably be wrong, will probably be shifted. So I cannot really use the QC as a calibrator at all. Now, when I said that I use QC to test my system, if I run my QC in a different way to what I run my sample like, then, for example, I run my QC using a start max. Okay, and I incubate my QC at 40 Celsius, but I incubate my samples at 37 Celsius. For example, supposing we can change the temperature. So if I incubate my QC at 40 Celsius and then incubate my samples at 37 Celsius, maybe my QC is fine, but maybe 37 Celsius is not enough to give good results for the patient. So now my QC is telling me that the analyzer is fine, whereas the patient samples are not good. So when I test QCs, they must be run in exactly the same manner as I'm testing my samples, because you never know what variable can affect your patient samples. So I have to subject my QC to exactly the same process that I run my samples. Sometimes this is not exactly possible, but I have to make sure that when I process my QC, it has to be in as close as possible conditions to how I process my patient sample. So whatever variable affects my patient sample will also affect my QC, and if this variable causes too much change, my QC will fail, so I will stop testing on the system because it's not functioning as intended. Something is wrong with it. Now, how often do I need to process my QC? Now, this is a question that is different in terms of its answer, depending on the parameter, depending on the type of the analyzer, depending on the kind of work you do in the lab. So for example, for electrolytes, you have to run your QC every little bit because, for example, the way you measure electrolytes, these analyzers are not very stable, etc., etc., etc. So I need to run my QCs more often. So then what is the rule? How do I decide? There is no one answer to this. Okay, usually this is something determined by the manufacturer. If not determined by the manufacturer, some accreditation bodies tell you to run QC every so and so. For example, clotting assays, you have to run according to CAP every 8 hours. Or sometimes the lab decides based on certain criteria that they have. So there is no one answer. There is no one standard. It varies from parameter to parameter. It differs based on the workload of the lab. It differs based on many things. So the summary is there is no one answer. It depends. Now, I know how to run my QC. I know how often to run my QC. Now, when I get the results of the QC, how do I evaluate the QC? Okay, I have manufacturer ranges. I run my QC. QC is within manufacturer ranges. Good. This tells you generally in a very wide image or in a very general image that your QC is fine. But again, we said that the manufacturer ranges are wide. So how do I know if I have a shift of 1 or 2 seconds, for example, in my PT? How do I know if I have a shift of 4 or 5 seconds in my APTT? My analyzer is reading prolonged readings of 4 or 5 seconds. Okay, maybe you are still within manufacturer range. So how do I know then if I have a shift in the performance or no? Now, of course, you have all seen this graph, accuracy and the precision. The point I want to make here is, when it comes to working with a QC is a very objective thing. Very objective means give me data, give me numbers. When you tell me my QC is good, my QC is bad, show me the number that made you decide that your QC is good or your QC is bad. Okay? So when I say I evaluate the accuracy and the precision of my QC, what are the numbers that I use to decide that I am accurate? What are the numbers that I use to decide that I am precise? Now, when it comes to accuracy, we said that we have the manufacturer ranges. If I am within this range, I am okay. But we said these ranges are wide, so they will not be able to detect smaller errors unless you have very big problem with your QC, very big problem with your reagent, very big problem with your analyzer. You are unlikely to be outside of the manufacturer ranges. So this is not the best way to evaluate your QC. Now, we have something called lab ranges and lab mean. What does that mean? We will come to it in a couple of slides. And we have another way, which is basically comparing my QC performance to all the other labs who use the same lot. For example, I'm using lot number 123. Okay, so this lot, for example, is reading slightly on the higher side for APTT for all the other labs. But when I compare to the other labs, I find that I am reading below the other labs by 3 seconds. I am always lower than the other labs by 3 seconds. At this stage, I know my analyzer is reading a shorter time than I should expect. Maybe this is impacting my patient samples. So again, the better way to assess your analyzer's accuracy or QC accuracy, that is, okay, the best way is using the externalized IQC, EIQC, externalized internal quality control. This is actually, there's a service from Stago called My Expert QC that allows you to do that. This is the best way possible, but this is not something that you can do every day. The next best thing is to use lab ranges and means. They will help you catch shifts or changes in the analyzer performance much better than the very wide manufacturer ranges. We will come to that in a bit. Now, the second point that I need to assess is the precision of my analyzer, my reagents, etc., the whole system. Now, precision is simply how close are my runs to each other. So for example, if I run my QC today, it gives me 12 for PT. Tomorrow it gives me 16 for PT. The day after it gives me 20 for PT. This is unacceptable. These are huge ranges. These are very huge. Sorry, these are huge changes. What if the same change is impacting my patient? And for example, PT is used to control the dosing for warfarin. So today I have to give my patient warfarin. Tomorrow I have to stop the warfarin. Maybe my patient will bleed. Okay, so my analyzer and my reagents, they have to be very precise. The results have to be very consistent from day to day, from run to run for the same sample. So precision is very important. How do I know if I am precise or no? What are the numbers that I use to decide if I am precise or no? We have something called the standard deviation, and we have something called CV, coefficient of variation, and it's expressed in percent. So it's CV percent. So standard deviation and coefficient of variation are the way that I quantify my precision. Now, Stago gives you, for most parameters that you measure on our systems, gives you SD and CV limits that you should perform within. So for example, your PT should function within 3% CV by the end of the month. Or when I have, for example, runs on multiple days, my CV should be, for example, less than 3%. Okay, so if my CV is higher than 3%, the higher the CV, the more the less the precision that is. So if my CV is higher than what Stago is claiming, so this means I have problem with my precision. Again, the higher the SD value or the higher the CV value, the less your precision. Okay, less precision means less consistent results. Your results are bad. They are changing quite a lot. So if I exceed the Stago claims, when I'm looking at the SD or the CV to assess my precision, if I exceed the Stago claims, then I have problem with my precision. Okay, so this is how I objectively evaluate my precision. Again, these documents are readily available, Stago claims for precision. I will add them on the group for you to have all the documents that we are talking about in this presentation. Now, we will come back to the lab means and lab limits, but there's a small point here to be made. Now, as you all know, we express, or we basically, display, or we visualize QC using algae graphs. Now, if I just look at an algae graph, things are within manufacturer ranges, that's it, my work is done. No. The whole point of LJs, Levi Jennings, or these visuals, is to actually help you catch errors much easier than just by looking at tables of numbers. So if I say, for example, that my results are all going up slowly, one after the other, maybe there's something wrong. Maybe my reagent is deteriorating. Maybe my analyzer is having a problem. What if, for example, I'm reading here, then my results for the QC all shifted up all of a sudden, and they're all reading high results? Then the LJ will tell me that just by looking at it. So it's a very good way to assess how my QC is performing. However, again, we said the QC is objective. So I need to know, what if, for example, just 2 runs were high, then everything went down? Is this enough for me to say that there's a problem with the analyzer? What if 5 runs were high, then it went down? Is there enough for me to say there's a problem with my analyzer? Now, this is where Westgard rules come in. I'm sure all of you have heard about Westgard rules. Westgard rules, in part, they help you to assess. When I look at the LJ graph, and they have this many runs higher than this much value, I have 1 run higher than this much, I have 3 runs increasing, I have 3 runs decreasing, for example, then I have an issue that I have to investigate. If I have just 2 runs decreasing, then there is no problem to investigate. This is how Westgard rules work. However, you have to be careful, because this is just a couple of examples of Westgard rules. I just add them for your reference. Now, you have to know that using Westgard rules is not just, I have all of these rules of Westgard, I will use all of these rules of Westgard. It's a little more complicated. And there is one very critical mistake that many labs make with Westgard rules. You do not apply Westgard rules to manufacturer ranges. Westgard rules must be applied when you have established your lab means and lab limits. I will say it again. Westgard rules should not be applied in general to manufacturer ranges. Okay? They should be applied when you have established your lab means and lab limits. I don't want to go further, because it will consume a lot of time, but this is very critical. This is a mistake that a lot of labs do. They apply withdrawal rules to manufacturer ranges, and they end up with having to do a lot of corrective actions unnecessarily. So this is one of the most common issues I used to see with customers in the field, using withdrawal rules in the wrong way. And it will generate a lot of headache for you and for them. They will think something is wrong with their analyzer, where actually there is absolutely nothing wrong, just because they followed withdrawal rules in the wrong way. Now, how do I work with lab means and lab limits then? What is lab means and lab limits really? Now, lab means and lab limits in concept are very simple. So I receive a new lot of QC. Let's call it lot 1 to 3. So lot 1 to 3, of course, has the manufacturer ranges with it. So the manufacturer tells you for your PT for this lot number 1 to 3 should read between 12 and 16. Now this is a wide range. So then what should I do as a lab? When I receive this lot, I do not use it right away. I will run it over 10 to 20 days, 15 to 20 days, different labs, different SOPs. Now, by the end of the 20 days or the 15 days, I need to have at least 20 runs of this QC, of this vial. Now, what do I do with these 20 runs? With these 20 runs, I will calculate first the average of the 20 runs. This will be your lab mean. With the same 20 runs, I will calculate the 2 standard deviation. This will be your lab limits. Again, with the 20 runs of QC, 20 runs for level normal, 20 runs for level pathological. So for level normal, for example, I have 20 runs. I will calculate the average of the 20 runs, and I will use it as a lab mean. For the same 20 runs for normal, I will calculate the 2 standard deviation. I will use it as my lab ranges, or I use it as my lab limits. Okay, so the manufacturer says my ranges are 12 to 16. When you did your 20 runs and calculated your 2 standard deviation, you will find that 2 standard deviation around the mean value that you calculated. Let's say the mean value was 13 and your 2 SD was 1 second. So 13 plus 1, or 13 plus 2 SD, which is 1 second, 13 minus 1, or 13 minus 2 SD. So my range will become 13 minus 1 is 12, 13 plus 1 is 14. So my range becomes 12 to 14. The manufacturer range was 12 to 16. So now my range became narrower than the manufacturer. What does this do? If I have shift in performance, all my readings started to be high, then my QC readings will be out of this range. I will stop. I will know something is wrong. So when I use lab means and lab ranges, I catch problems with my QC much earlier than if I use the manufacturer range. This is the main reason I use lab means and lab limits, because they are narrower, so they will help me catch problems with my QC earlier than the manufacturer ranges. And this is very important, because what if I have a shift of 2 seconds, for example, in my PT and I don't know? This will impact my patient treatment. So it's very critical for me to catch issues earlier on, which is done by establishing the lab means and lab limits. So what is it for? Is to catch errors earlier. Why would I do this? I mean, a lot of labs will tell you, okay, this is a headache, I don't have to do it. Now, a lot of labs, they want to save on cost. A lot of labs, they don't want to have headache. They don't want to do the extra work. I understand, fine. This is what everyone will say, what your customers will say. However, you are jeopardizing your patients in many cases. Maybe you have a shift that you don't know about, or a trend that you don't know about, and it's affecting the treatment of your patient. Maybe it's causing adverse health effects. How do you know? That's why when I establish the lab mean and lab limit, I reduce the risk to the patient by catching the problems with my system earlier. Plus, which is the bigger motivation behind why many customers do it. When you have a CAP accreditation, when you have ISO accreditation, when you have JCI accreditation, you must do lab means and lab limits. Part of the inspection, they will tell you, where is your lab means and lab limits? How did you establish them? Can you show me the results that you used to establish them? Okay, so lab means and lab limits are very important to catch errors. Plus, okay, for this reason, because they help you catch errors, they are mandated by CAP, ISO, and JCI, and many other accreditation bodies. Now, if the customer still insists on using the manufacturer limits, again, you cannot force their hand, but you have to be careful when it comes to interpreting the QCs. Because, for example, many times when you use manufacturer ranges, okay, the customers will basically create something that's called a target. It's the middle point of the QC that comes from the manufacturer. They will tell you, okay, QC from Stago says 12 to 16. Stago says 12 to 16 is the range for PT. Customer will say, okay, then your target is 14. There is a very critical point to understand. For QCs, there is no such a thing as target value. QCs simply just give you ranges. Stago just tells you from a 12 to 16, if your analyzer measures within this range, that's it. You are okay, according to Stago. You are generally within the performance claims of Stago. However, okay, as we said, remember when we established the QC ranges, we run on a satellite, we run on RMax, we run on a compact max in our factory. So the compact max maybe is reading slightly less than the RMax, reading slightly higher than the satellite max. So if the customer says, okay, your target is 14 because it's exactly in the middle, this must be your target. Maybe your compact max in the factory was always reading 13 seconds. So in this case, you'll always look like you are below the manufacturer target. The customer will call you up, your analyzer is reading on the lower side. Come and fix it. But there is actually really no problem with the analyzer. Okay? But then you don't have the target for compact max in the sheet. So how would you know? This is where externalized IQC or comparing to other labs comes in very handy. It becomes very useful. So I will look, okay, this lot, my compact max for this lot, how much was it reading in other labs? So you just take your data, put it on this My Expert QC platform. My Expert QC will give you the answer. It will tell you your compact max is reading 13 seconds. All the other labs are reading 13 seconds. You tell the customer, see, you are saying the target should be 14, but all the other labs are reading 13 seconds. So your analyzer is fine. You don't need to complain. Stop complaining. So using the manufacturer limits, it can be a tricky business. However, once you receive the lot and you establish your lab means and lab limits, your new target will become the mean that you have calculated from your runs. Your compact max is reading 13 seconds. So I calculate the average of my compact max. It says 13 seconds. You use the 13 seconds as a target. Now all your results are on target with the lab mean. Okay, so now the customer does not complain anymore about a problem that does not exist. Now, last very important problem here. Again, Westgard rules. Only use the Westgard rules after establishing lab means and lab limits. Otherwise, you'll have a ton of issues which are not really issues. The customer thinks there's a problem, a Westgard rule is violated, but actually the Westgard rule is not violated. You're just using the Westgard rule wrong. Now, again, I cannot spend that much time on these points because they will take a lot of time to basically elaborate on. Maybe in the future we can cover it more in depth. But these are the general points that I wanted to make, which can really save you a lot of headache, a lot of issues. Now, again, this is just a quick summary for what we said. So how do I establish my lab means? I just have to have at least 20 runs over 10, 15 to 20 days. From them, I will calculate the mean, which is just simply the average of the 20 runs. And I will use this mean as a target. From the same 20 runs, I will calculate the standard deviation. Then I will multiply it by 2. I will get my 2 standard deviation. So my target value plus minus my 2 standard deviation will give me my target plus my limits. And the lab will have to use this as their new ranges. When do I do this process? For every new lot of QC. And you receive QC lots every few months, so that should not be a problem for the lab. Now, moving on from QC. By the way, if you have any questions about these topics, yes, Ibrahim.
Yeah, there's, I think, one very important point that was missed here when we were discussing lab mean and lab SD. There is actually this lab mean and lab SD should be done while we have a current lot that is already running. So the current QC lot we would be doing. While we are doing that, we will do the new lots mean and SD, because otherwise, how would we know our QC is actually in control while we are establishing the new mean in SD for the new lot?
Exactly. See, you have a very, very valid point, and I agree with you 100%. It's a critical. But to be honest, I could not add all the points in this presentation. I wanted to keep it simple. But I agree with you. You have a very good point. Thank you, Ibrahim, by the way, for this addition. Julius, I'll get back to you. Just let me finish this section, and I will get back to your question, just for us to be within time. Okay, so You have all heard of something called validation or verification. More commonly, it's called validation. Now, what exactly is this validation? And why did I not call it validation? Why did I put performance verification? Now, validation in the lab usually is thought of as follows. So I get a new analyzer from Stago, Sysmix, whatever. So Stago says my analyzer can do so and so and so. I, as a customer, I need to verify, is Stago just telling me stuff to sell me the analyzer? Or is this analyzer really functioning or really working as Stago is claiming? So I, as a customer, must verify Stago claim, because otherwise there's a conflict of interest. Of course, every manufacturer will tell you my analyzer is the best in the world. It does everything for you. Okay, but me as a customer, okay, I need to verify that because Stago wants to sell me at the end of the day. I mean, it's a company at the end of the day. So I need to verify, is Stago really delivering what they are promising? So whenever I receive an analyzer, I have to verify, is this analyzer precise? Are the results produced consistent? Is this analyte accurate? Is this analyte measuring over the whole range it's measuring, it's claiming to measure, and so on and so forth. So every analyzer, every reagent that I have to use, I need to verify its performance. I need to make sure it functions as intended. So now we have two terms. We have validation and we have what's called performance verification. So I, as a customer, when I receive the new analyzer, as we said, and I test its performance, we call this performance verification. I am verifying the performance that Stago is claiming. Now, then what is validation, you will ask? Validation is actually, if you want to be technical about it, validation is simply, I, as Stago, have made a new test. Okay, I will call it test X. Now, I invented this test. This test, for example, is used to measure factor 13, so to speak. So I need, as a Stago, to make sure that this test actually measures factor 13, doesn't measure something else. I need to make sure that this test is actually precise. I need to check what are the things that interfere with this test. I need to make sure at what temperature should I incubate this test, etc., etc., etc. So there's a lot of things for me to check. So validation is something usually that's done by the manufacturer to actually discover what this test can do and what it cannot do, what interferes with it, what are its limitations. So validation is not something that a lab can do. Usually it's something that's done by a manufacturer for a new test, or when I modify a test, I need to validate, is it still functioning as intended? Okay, what I do in the lab, I just verify what the manufacturer is claiming about their test. Okay, I don't have time or resources to do validation as a lab. I just do performance verification. So usually validation is restricted to a manufacturer, but people use validation commonly to talk about performance verification. Anyways, so why does this concern us in application? Now, you know, a lot of cases you will install an analyzer, the customer will tell you, I want you to do the validation for this analyzer. You will find that the customer is not really aware of the details of how to do this performance verification. So simply, what do you need to know? You need to know that when I verify the performance, then I'm simply testing the analyzer to see if it meets Stago claim. So Stago says my analyzer is this precise. I need to test, is it really this precise? Stago says my analyzer is this accurate. I need to test, is it really this accurate? If it really is within Stago's claim, then I, as a customer, I am sure that this analyzer is performing well. Now, if Stago doesn't have a claim, what should I do next? If Stago does not offer you a claim, which everything is covered basically from Stago side, but suppose Stago doesn't have a claim, or whatever company doesn't have a claim, what should I do? There are regulatory bodies that offer you claims on each parameter. For example, they will tell you PT precision should be this much, PT accuracy should be that much. For example, you have CLIA claims, you have GFHC claims, you have RCPA in Australia, okay? So this depends on the customer, what they want to use. They decide what kind of regulatory body or regulatory standard they want to follow, okay? So this is the customer part. But always what I do first, my priority is to verify Stago claims. Stago claims do not exist, or the manufacturer claims do not exist. That's the time that I will move to using the regulatory standards. If the customer insists on using the regulatory standards, that's their choice. At the end of the day, actually, the customer is the one who should be doing the performance verification, not us. But again, as you know, in many cases, they simply don't have the enough know-how to do it. Or sometimes they just want to throw it at you. Anyways, so In Stago, we have some documents that will give you the claims from Stago, and again, I will be sharing these with you. So what are the procedures that I need to do then for performance verification? Most commonly, I need to check first accuracy. I need to check precision. I need to check carryover. I will explain each. I need to need to verify linearity, or something called the analytical measuring range verification. And I need to also verify the reference intervals that I will use to report my patient sample. Now, some labs, they will want to do more things like limit of detection, sensitivity, etc., etc. That's a different story, but we're talking about the basics here. So accuracy, how do I check my accuracy? Accuracy basically is how true is the measurement that I'm doing. When I get an APTT of 35, is it really the accurate measurement? Maybe my APTT should be 50 for this patient, but my analyzer is not measuring correctly. How do I check this accuracy? Okay, how do I measure that I'm actually close to the true measurement that I should be obtaining? Now, the most common approach I have is by using comparison. I compare my new analyzer to the same exact analyzer, or at least within the same manufacturer, using the same methodology and using the same reagent. So for example, I can compare a compact to a StarMax, okay, because both are using the same methodology. They're using mechanical detection. I cannot, for example, compare a compact max in many cases to a Sysmex machine, because Sysmex uses optical detection of clots. For example, I have a reagent, APTT reagent. I cannot compare PTT automate reagent to recombinant plastin from IL. They are two different reagents with two different performances. I compare PTT automate on a Stago machine to PTT automate on a Stago machine. Okay, you have to be aware that reagents can create a lot of differences, and there are many reasons. We will come to cover them in different sessions. Different methodologies, different ways of measuring the clotting time, the concentration of proteins or factors, they can have very big differences. So I cannot compare different analyzers and expect my results to match. In most cases, that will not happen. So instrument comparison has to be the same reagent on the analyzer, perfectly the same analyzer. But if that does not exist, an analyzer that has the same exact methodology for measuring. Okay. Now, another way that will help me have a good idea about accuracy is by using PT programs, or proficiency testing programs, like ECAS, like RECAS, like CAP samples. Okay, they will give you a very good indication of your analyzer accuracy. However, these usually require the lab to be accredited or within accreditation, and they're usually expensive. So in most cases, I will have to resort to instrument comparison by comparing a new analyzer to another analyzer that's already validated, that I know its performance is good. Now, what kind of samples do I use in comparison? You have to use patient samples as much as possible, because what I'm running on this analyzer is patient samples. If I use a QCs, QCs are slightly different from patient samples in their composition, basically. So ideally, I will use patient samples, normal and abnormal. There is something also called Expert Core. It's a product from Stago that offers you samples which are normal and abnormal for D-dimer, samples with heparin, low molecular weight and UFH, normal abnormal samples in terms of INR, and a few other details. So some customers, for example, they want to have samples which have different concentrations of heparin, but you don't always have that available for you. Different samples with very high D-dimer, but you might not have always this kind of thing available. You can buy this product for your customer. Okay, so you give them one box, you give the lab where you're comparing another box. Once they run the samples, you compare them together. Okay, so if the customer does not have the patient samples which allow them to do the comparison, you can use the Expert Core to cover basically whatever is missing in terms of patient samples. We will talk about that later on in a different session. Precision simply is composed of simple precision or complex precision. It might sound very technical, but it's not. Simple precision is simply, I get one patient sample or a QC, I run it 10 or 20 times now. And I check the CV and SD. Is it within Stago claim or no? Within Stago claim, precision is verified. Simple precision is verified. What's complex precision? Complex precision is simply, I run my QC over multiple days, multiple operators, multiple vials of reagents, which of course will introduce more variability. Then I will check my CV and the standard deviation. Are they within a Stago claim or no? If they are within a Stago claim, then I say yes, simple precision is verified, complex precision is verified, then a precision overall is very good for this analyzer. It passed. So I say precision is passed. Now, in terms of carryover is simply when I run a sample, for example, with high concentration of heparin, if the analyzer is unable to clean the tubing or the pipettes or the needles properly, maybe the heparin will move to the next sample, will cause a prolongation in the next sample, but the next sample is actually normal, but now it looks like it's abnormal. So I need to verify with carryover, I need to verify that the analyzer is able to clean after each sample in a way that it prevents the contents of one sample from moving into another sample, the sample after it, and causing the second sample or the sample after to be incorrect. Now, linearity. Linearity sometimes is used interchangeably with analytical measuring range verification, AMR's analytical measuring range. They are not really one and the same. Okay, linearity is one component of the AMR verification. Linearity in most cases is referred to, I will get samples with different concentrations covering the whole measuring range that Istago is claiming. For example, Istago says I can measure factors between 1% and 400% for factor 8, for example. It will be good if I get samples from 1% to 50% to 100% to 200% to 400%. Then I will measure them. Okay, if all these samples are measuring as expected, I will say that the measuring range that Istago is offering is actually accurate. I am able to meet, or I'm able to measure within this range as Istago is claiming. However, if I'm trying to measure very high samples like 300, 400, okay, I know they have 300, 400, but then the analyzer is reporting that, oh, your sample has just 60 or 70%, which is wrong. So in this case, I know the analyzer is unable to measure high samples properly. So I have a problem with my linearity. Okay. Or I have a problem with my AMR. Again, a lot of times they are used interchangeably, but they are not exactly the same. There's a few differences, but for the sake of time, we will not go deeper into that. So again, linearity is simply me trying to verify that my system, my reagent, my analyzer is measuring over the whole range that Istago is claiming my system is measuring over. Okay, so if my very low results are reading all high, I will not be able to classify my patients properly. Wrong treatment for the patient, wrong diagnosis for the patient. If my high samples are reading low on the analyzer, again, it's wrong diagnosis for the patient. One point I forgot to mention, how do I evaluate instrument comparison? There are claims that work as follows. So I have this result on my new analyzer, I have this result on my old analyzer. What is the allowable difference between the two? So if the difference between the samples exceeds Istago claims, then I will say this difference is unacceptable. Okay, then my comparison is bad. Okay, and usually there is more specific guidelines. So for example, some guidelines tell you you can accept a maximum of 5% of your samples exceeding this range. So 95% at least of my samples, they should be within the manufacturer claim of difference between two samples. Stago also offers you these claims. So for PT, for example, when you are comparing Stago analyzer to a Stago analyzer should not exceed this much. Okay, so these claims are available. I will send them to you in the group. I will send you also a few documents if you want to read further about these topics. Finally, which is something very important, reference interval verification. Now, what does this mean? Now, you bring your new analyzer to the customer with a new reagent to this customer. So they try to measure their samples. They find that there's a lot of their samples out of a Stago range or out of the range that they are trying to use. They will tell you, oh, your analyzer is bad. Come and fix your analyzer. Your reagent is bad. Find the problem with your reagent. Now, it's very important to understand that when I want to use a new range in my lab, I have to make sure that this range is actually compatible with the population that I am working with. So for example, Stago says for APTT reagent, APTT automate, the range is 30 to 40 seconds, for example. Okay, you have to verify that this 30 to 40 seconds is acceptable for the population you are treating. For example, this 30 to 40 seconds in Istago IFU, for example, it's for adults. If you use this range for pediatrics, of course it will not work because pediatrics, they will give you different results. Okay, so whenever I want to use a reference range as a customer, I must verify that it works for my population. I cannot just use it blindly. Okay, now the customer maybe will come to tell you, oh, establishing ranges is very difficult. Now, when I say establishing ranges, it means I have to create my own range from zero. This is usually a very difficult process. No one will do it. Then what do? I can simply take a Stago range, the one that's in the IFU, or a range in the literature, for example. I will look to some papers. Then I will do a verification procedure. Again, if you want us to cover these things more in depth, how to do each and every one, it will be a different session. I just wanted to draw here some general points. I have to verify Stago range. Then what is this transference? Transference is the same as verification, but it's, let's say, a less strict method of verification. So transference and verification, they are the same. Verification is usually a little more difficult, but it's better. So if the customer doesn't want to do the verification, they don't have the resources, they are too lazy to do it, or whatever it is, they can go with the transference. It's usually followed by many customers, and it's the easiest. Establishment, very difficult. Some cases it's not possible, like D-dimer, you cannot establish your own ranges. What can I do then? I will do verification. The customer doesn't want. What's the easiest thing to do? Transference. Now, what does Stago offer you to help in terms of this performance verification? First, you have something called biological test sheet. This biological test sheet is simply an Excel sheet that will allow you to fill the data that you obtain from these studies. So when I do the sample precision, which is I run a sample, patient sample, or you can see now in the same batch, basically 10 or 20 runs. You can plug these 10 or 20 runs in this Excel sheet, and the sheet will tell you it's okay or not within Stago claims. So you know you have passed sample precision. The same applies to the carryover within this sheet. Okay, there's a specific protocol. Okay, you run carryover using this protocol, 10 samples APTT, then 10 samples PT, then 10 samples PTT. You put these results in the sheet, it tells you pass or no. Finally, you have in this sheet a comparison between capped samples and uncapped samples. So if the customer, for example, wants to change their tubes from capped to uncapped, or the other way around, then you can run the capped samples, you run the uncapped, the same samples while they are capped, and you plug the data in the sheet, it will tell you pass or fail. What else? We have something called performance qualification. This is a document that I will share with you that will give you the exact protocols on how to run this performance verification. Now, very important point. This is just a suggested procedure. If the customer have their own SOP, they have 100% the freedom to use their own SOP. They want to use, for example, some protocol from a certain regulatory body, it's their business. We can just suggest this. The customer wants to accept it, it's their business. They don't want, it's up to them. Okay, but this is just a procedure suggested by Stago. You are not forced to use it. The customer is the one who decides ultimately what they want to use. Now, you have also precision and correlation claim documents. So you have Stago claims for a precision, okay? And you have Stago claims for comparison or correlation studies, okay? So in the correlation document, it tells you, for example, if you run, again, PT between compact and the compact using neoptimal here and here, the difference should not be more than this much in percentage, for example, okay? So when I run the comparison, I have a criteria to compare my two analyzers to know if I have passed or failed. Finally, in the kit insert that comes within the kit itself, you have the reference intervals established by Stago. The customer can use them, but the customer needs to verify these ranges because they simply may not work well with the population they have, okay? In the same kit inserts, for some kits, you have something called the limits of detection. Some customers, for the sake of accreditation, they will tell you where are your limits of detection for your kits. You will find them in the kit insert inside the box. Okay, because this is very important, for example, for some CAP accredited customers. Now, speaking about accreditation, now there is no, I cannot say there are rules that govern accreditation in terms of the same thing applies to CAP, the same thing applies to ISO, the same thing applies to the GSCI. Now, before we go into that, what exactly is accreditation? Accreditation is very simply, I, as a lab, I do laboratory testing for whatever, coagulation, hematology, doesn't matter. So I need to have certain standards for me to do my work. Otherwise, my results will be different from the other lab, and maybe I'm releasing very bad results. My quality standards will be poor. So accreditation simply gives you a set of guidelines, which are usually set by experts, usually set by international bodies that you have to follow. So it's a set of guidelines for a lab to follow to say that its performance is good. Okay. Now, what does that matter to me? For you as an application, why is it important for me to know about accreditation? Because accreditation impacts pre-analytical work, the way the customer handles the samples, which inevitably will affect also the analytical work, how the patient, how the customer runs a QC? How many times they run QC? How do they run their samples in some cases? How do they work with their results? So you will get a lot of queries from the customer. How should I do this? What is the CAP recommendation? Or they will do something. This is the way CAP recommends it. But for example, it might give you problems. But if the customer doesn't understand the accreditation, a lot of problems will rise up. So it's very important for you, if your customer, for example, is using CAP or is ISO accredited, for you to understand what are at least the general points in CAP. Okay, because for example, when I run the CAP PT samples for PTT Automate, you need, and this is just unique to CAP samples only, for CAP samples, you need to multiply the CAP result for PTT Automate by 0.85 before you submit. If you don't know this, then you will be getting wrong proficiency testing for CAP results. Okay, you need to also understand how the customer evaluates the CAP samples, because in many cases, the customer will tell you my CAP samples are out. So you need to understand how to evaluate these CAP samples. So again, what's the point of you knowing about accreditation? It directly affects your work in supporting the customer. Okay, so where can I find these guidelines? How can I read about this? How can I understand this? CAP has its guidelines, ISO has its guidelines, JCI has its guidelines. So for example, I will be sharing with you on WhatsApp the CAP hematology and coagulation checklist, or this is their guidelines. But for ISO, there are guidelines that you can take from the customer. You can also ask the customer for these guidelines. It's not restricted. You can take it from them. Or if the customer is following JCI, you can ask them, what are the guidelines? It's good for you to read, to understand what your customer is expected to do. Because again, it will directly affect your work. Many cases, I had customers tell me, my QC is not acceptable, so and so and so and so, only to find that they're following the CAP guidelines wrong. And they're creating a headache for something that does not really exist. So it's very important for you really to know about accreditation. Now, again, to summarize, what does accreditation impact? It impacts how they handle QC, how many times they do QC, for example, how many times they run calibration. For example, CAP tells you to run calibration every 6 months. Okay, how do you run your external quality control, etc., etc., etc. It affects sample collection in some cases. It affects how they do their pre-analytical work, which directly again affects your analytical work. Also, accreditation requires some of the customers to do the method verification or the performance verification in a specific way. So maybe they are doing it wrong, and you need to help them. You need to guide them. Or maybe they will create you an issue that, oh, your analyzer is failing performance verification, but they're just following the accreditation guidelines wrong. So it's very important for you to understand how these accreditation guidelines work. And that's it. If you have any questions, please let me know. I remember, Julius, you had a question. If you please let me know.
Hi, hello.
Hello, Julius.
Yeah, I have one simple question only
Yes.
regarding that lab mean and lab limits. Yes, we do the WISGUARD rule. Is that WISGUARD rule enough, or this for the stagger reagents is the Six Sigma rules is applicable too?
See, first of all, before applying WISGUARD rules, as you remember in the slides, the customer has to establish lab means and lab limits. When you're talking about Six Sigma is simply a standard for reducing errors in the lab as much as possible. Okay, if the customer is working to obtain basically Six Sigma, WISGUARD rules are involved. Okay, but this is, you can say it's a more complex topic, because you cannot use all WISGUARD rules at the same time when it comes to Six Sigma. Actually, the better your performance is when it comes to Six Sigma, the less WISGUARD rules that you use. So yes, your customer should be using WISGUARD rules if they are trying to obtain 4 Sigma or 5 Sigma. But the idea is they need to know how to use it properly. They should not just be using all WISGUARD rules at the same time. WISGUARD rules, in most cases that I have seen, they are used in the incorrect way by customers. I hope this answers your question, Julius. You're welcome.
Thank you.
Okay, any other questions?
Yes, Lais.
Hello, Abir. Good morning.
Thank you
Good
for
to see
this
you.
nice presentation. Really, it's
You're
very
welcome.
attractive. I attended it in order to link to some says the issue we are facing with the quality control. My first question is why you choose the session of quality control to present in the beginning of the year? Then I have two other questions.
Yes.
Okay. Second question, really it's very critical. Yani, after I attend, I know that we have a lot of statistical parameters that a lab should use in order to perform. Really, I'm so surprised, and especially for coagulation, which are life-threatening tests, I believe. It's very crucial working with PT and PTT and factors. And from our experience here in Lebanon, really it's so strange. For the last 3 years, we are facing a huge drop in our quality control sales reagent. Yani customers are running quality control every 48 hours. I don't know how much it's so robust, the reagent of Stago, that customers are not afraid. So really, it's you mentioned that we have manufacturer rules, we have the mean of the lab, we have international guidelines and statistical West Guard rules and others. And I don't know. I'm talking about academic big hospital. I'm not talking about a center that has 5 or 10 samples per day. How they are not afraid, how they monitor their performance, and 24/7 shifts and without running an accurate control. Really, it's so strange. Third point, how to run a campaign on quality control. Really, because if we face a drop of 60% of our sales, it's a number for stack control or system control. So three questions.
Okay. First question. I don't know why I made it beginning of the year. Actually, I just put I put a poll in the application group, and this was the most requested topic actually, and it makes sense because it's something everyone faces almost every day, and it's a big headache for everyone. So, well, that's by popular demand. Now, the second question. To be honest, why do customers do things in such a way? It's a question that I am having in my head for 6 years. I never had an answer for. Now, for CAP, for example, CAP asks you to run QC every 8 hours for clotting tests. At least for PT, PTT, FEB, the routine stuff, at least. Now, many customers, of course, you have the cost issues, and many customers, they think, why do I need to run it multiple times? What is this headache about? The QC will be stable. Stago just wants to sell us more because they say 8 hours. Now, for QA control, the claim is 8 hours. Beyond 8 hours, it might live a few hours. And I'm telling you from customer experience, not my personal experience. Many customers, they say it can live, okay, a few hours after the stability is gone on board. But we don't have stability at Toto Elysis. We don't have stability at in the freezer. We don't have a claim. Our claim for QA control is just 8 hours on board. Again, might live a few hours, but a full day, it's very unlikely to give you good results for most parameters. It might give you for some, for the others not, but it's not very good QC. 48 hours using the same vial of especially QA control, very bad idea. The same applies to system control. Routine control stability is 24 hours. It lives a little longer, but the same applies. 48 hours is too long. So, customers, they want to cut costs sometimes on the expense of quality, which is, okay, I understand there must be a balance in the lab's expenses with the quality, but sometimes they push it too much. But again, this depends on the lab, and there is no single answer, to be honest with you, Abir. But I have seen the same happen over and over again. They want to reduce cost on the expense of quality. Now, I understand we're not exactly living in European countries where they have very big budgets in the labs. Even in Europe now, it's not big budgets anymore. But still, you should have at least a standard for the routine. I'm talking about PT, PTT, FEB. But again, this has to be discussed with each lab individually because, different labs, they will have different reasons. I know some labs, for example, they wanted to run 3 times QC a day on CBC instruments. When I asked them, why did you want to do it? They said, oh, we just felt it's better. But there is not a single guideline that asks you to run CBC controls, for example, 3 times a day. So it depends on the case of the customer, to be honest with you. But again, the vast majority is just a matter of saving costs on the expense of quality, sometimes quite incorrectly. And that will be actually to their detriment. Because after 48 hours, your QC will be out. You have to go repeat it, corrective actions. You will be wasting more agents and more QCs. So you're not saving, you're wasting your time, you are giving yourself headache unnecessarily.
I believe that accreditation is a tool that that it's very important that stimulate customer to be aligned. In case no accreditation, customer feel his life free. And he lives as he would like to. He is manipulating the system at the end.
Yes. And see, to be honest, it also depends on the local regulators. Because, for example,
Yes.
some countries you are forced to be accredited. For example, now in Dubai, every lab that opens has to have at least ISO accreditation. In Jordan, for example, you are not forced to have an accreditation. It depends on the country, it depends on the city in some cases. So I agree with you 100%. So accreditation really helps standardize, really helps elevate the level of quality. But some customers, simply for economical reasons, they cannot go for accreditation because of the cost associated with it. So it really depends from country to country, city to city, customer to customer, budget to budget. So there is no one answer to all of the customers at the same time.
Okay. So third
And
one
for
for
your
a
third
campaign. Do you have
yes.
materials for a campaign digital marketing on quality control?
Of course, yes. See, it can be, your issue can be, something related to marketing. It can be at the same time a technical issue. For example, customers stopped because they saw a certain problem. So if you want, we can have a meeting. We can discuss this point so I can provide you with whatever material you need.
Okay. Thank you.
You are quite welcome, Abir. We will discuss it, inshallah, very soon.
Thank you.
You are quite welcome. Okay, so any questions? Anyone else? Yes, Ibrahim, with you. Please go ahead.
Oh, great. Can you hear me?
Yes, I can.
Yes. Okay. My screen went blank for a minute. So I have a question regarding this AMR verification. So the thing is, if the say calibration is, for example, not it cannot be extrapolated, and then you have an AMR which is given by the manufacturer, but then your high sample may be right next to AMR, and sometimes due to variation, sometimes it might give maybe greater than or something like that. So in that case, how do you verify the actual range? Did you understand my question? Am I being clear?
Sort of. So I understood that your sample is just above the AMR, and
maybe just below
because of
AMR.
variation it will come in.
Yeah.
Okay.
Yeah, maybe just below AMR. But in that case, but due to the variation in the repetition, even though it's very precise, there might be a bit variation which shoots. Sometimes it shoots above the AMR, and then it might give greater than or something like that. In which case, we don't really have the actual value. So how do we verify the actual, like the manufacturer's AMR actually? If you use a lower sample, then yeah, we get the value. But then what about the results above the sample that we are using? We haven't really verified the complete range in that case.
Okay. Now see, in case the calibration curve is not to be extrapolated, in case the calibration curve, you cannot extrapolate, like let's say second or third order polynomial. Sorry guys, it's a very, very specific question. I'll just address it quickly. In this case, Ibrahim, if you run, for example, first run it's within, second run it's out. Now this really, you can say more or less comes down to the lab. If the assay can be, of course, diluted to bring it in within range, then your problem is solved. But if you cannot do that, you have to use, for example, only nitroplasma or only a specific dilution. Then the lab has to decide, should we report it as more than this much, or should we report the first value, ignore the second value? It might depend on the test, for example. If it's a really critical test, maybe they want to investigate further, okay? Maybe they want to do a redraw, etc., etc., etc. So it's a very specific situation that depends, I think, on the circumstance. So there's not one specific answer because, the technical answer, you are out of the calibration curve, cannot be extrapolated, no measurement. I hope this answers your question exactly the way you want it.
Yeah. Okay, thank you.
You're welcome. If you want, by the way, Ibrahim, we can discuss it further. I can connect with you after this. You are quite welcome,
okay.
Asif. Welcome, my friend. Okay, no problem, Ibrahim. Okay, any questions before we stop the recording? Muhammad, you're trying to connect, or your mic is trying to connect for you?
Yeah, thank you, Les, for this amazing presentation.
You're welcome, Muhammad. You're welcome, my friend.
Thank you.
Okay, so I will stop sharing the presentation. I will stop the recording. I will send you the documents, as I said, on the group, and I will keep the presentation on YouTube, upload it, and I'll also send you the link on the group in case you want to send it, you want to get back to it, is there. We will, inshallah, in the future go back for more clarification. I know these are very general points. We did not go into details, but as you can see, the time is not our ally here. There's really no time to explain all of this. It will take a lot of time. So inshallah, in the future sessions. And you all have a happy new year, and see you inshallah soon in next sessions. Salam alaikum.
Alaikum salam.
Thank you. Thank you.
You're welcome. Bye.
Thank you, Liz. Good presentation. Thank you, and have a good day. Thank you.
You're